Let's go a little bit into business, and in order for you to know what I'm talking about today, something that I'm really happy and proud of, which is narrow diameter implant, and by definition, they are the implants that are less than 3 millimeter in diameter. Any implants that you're using less than 3 millimeter is called narrow diameter. They started calling it a new name, which is narrow body implant. That's really new in 2013. We used the temporary implants. Each one of the implants cost $20 at that time. Highly polished, and they were like one piece, 1.8 millimeters in diameter. I was impressed by this radiograph with definitive wide implants, and then accompanied by temporary implants. Started to use them routinely in our practice. This guy had this temporary bridge sitting on those 3 temporary implants. In order to remove the implants, it was a hell of force, and you can watch that no one implant is straight because of the amount of torque and force used to remove them. So it became like routine using the temporary implants, and in this special case, I left the temporary implants in place and fabricated this fixed bridge. It became routine in any distal extension cases to put definitive implants and combine with the temporary, then later on to remove the temporary and do a final bridge. A main advantage that the patient is coming to the office in edentulous and he wants to leave with teeth. Of course, it reduced the amount of edema too, and here are plastic caps to cover the temporary implants. Let's ask ourselves, what do we need in an implant? A rough surface, yes. Flutes, they thought it was anti-rotational. Of course, no, it's only for storing excess bone. Tapered apex and body, which means needs minimum drilling, and please, some points are very essential and like life-saving. You don't need a lot of drilling, you don't need heat. Simple, okay? Allows for both immediate and or delayed loading, which Brident, I have to say, Brident is not in Egypt yet. Brident, I mean as implants, are not in Egypt yet. I am waiting for them. I got a couple, I'll show you how I use them, okay? And the ability of an adequate soft tissue volume, the thicker the bone around an implant, and please, this is very vital. The more bone you have, the more soft tissue, healthy soft tissue you will have. And this is an extra piece of information for you guys that was published in 2012, just for your information, something very strange. What does it mean that I need to use an implant that was manufactured 4 weeks ago? That's the ideal timing for using an implant. Of course, I use implants that was manufactured a few years ago, but the ideal timing published here, okay, is 4 weeks. Anyways, I was selected as a chapter author in this book in the year about immediate loading. And then comes the book that Igor is talking about. I presented it as a course in Dubai last February, then in Las Vegas a couple of weeks ago. And I hope that one day you will read it or watch me talking about it. Let's go a little bit into business. When Dr. Stephen Attar, editor-in-chief of the International Journal of Oral Maxillofacial Implants, said, "Is implants a boutique type of service? Are you thinking about actresses and actors? Are you thinking about how to make a patient happy, or you are only trying to make this lady happy, for example, and to enjoy life again?" Then came Michael Picos, who is one of the best speakers around the world now. He comes from USA and really complained that people are studying perio, prosto, surgery, whatever, forgetting about real knowledge and only thinking about implants. Accordingly, the treatment plan would include implants whenever it's not really needed. They don't have enough knowledge. Then came Morton Perel, who I admire very much, and was talking about the level of the British masters and PhDs and talking that they are offering those without enough training and no enough knowledge. Just a warn. And talking about a disaster, they were reviewing an article in the Journal of Implant Dentistry. One of the referees said, I saw this photo before. Everybody was laughing, and then they discovered that the author copied this photo. It was of a cone beam, and he added it to his article, and this is forgery. This is very wrong, and it happens around the world, so please take care. I liked very much this statement by came in the Journal of Implant Dentistry last April. A guy just sent the journal, I am an implant clinician, all I want to read is in journals are clinical articles. I don't care about research. So, do we really know what we are doing? Maybe we should think in a human way. I'm just warning you guys, because we used to say to people that the symphysis area is 100% safe. It's not anymore after they discovered branches of the sublingual artery, and this is very strange, the mandibular incisive canal. You would get paresthesia in the lip without knowing the reason. You think you are away from the mental foramen when there is this mandibular incisive canal. Lots of cases. Professor Tal from Spain was talking to me. He gives his patients passports or stickers about the type of implants he puts, because the patient would leave, maybe the dentist leaves, maybe leaves upstairs even, but what's the type of implant to go ahead with work? Very strange, very long implant for no reason whatsoever. Implants everywhere. Here, I would go for a 3-unit bridge, single crowns, and a sinus lift for no reason. It really matters how you see yourself. Please, guys, put this in mind and go to this Journal of Implant Dentistry, and see what we were talking about, the nose, which is the cause of lots of problems. Here, would you believe that this patient is 21 years old? 21. Lots of post-encores and everything. I will not talk about this a lot. I will only tell you that in order to go ahead and save her, I had to buy an abutment for this implant, do a 4-unit bridge, but I'm showing this only to show you how I fix bridges, and this was published in the Journal of Prosthetic Dentistry under my name, 1995. It's a very nice way in order to remove excess cement, okay? And you know that excess cement have been proven to be one of the causes of implant failure. Here comes a case. If it was not splinted, no one abutment was placed in a correct way. So please make sure to do post-operative radiographs. A case with no attached mucosa, this will never heal. Very bad lab work, corrected later on. But let's go a little bit deeper and simplify our world and our patient's world. A young guy, a computer genius, not married, he found a girl, and he's going to get engaged in 3 weeks. Please, you need to do ortho treatment. No, I don't have this time. You need to take care. I don't have time. Please do anything. What I would do, what I had to do, is remove, prepare, do temporaries, and that's how he looked later on. Sometimes you cannot do what should be done. What are patients coming for? An implant or a crown? Of course, it goes without saying it's a crown. How many patients definitely need bone grafting? The answer was said by Dr. Giovanni. A patient said, no, I don't want. No surgery. And in the Middle East, lots of patients refuse surgery. How many patients accept surgery? Very few. How many patients care about eating now compared to caring about papilla? Let's be realistic. How many patients want immediate results? How many patients want the simplest treatment modality? How many dentists are afraid to work with implants? And I know a lot. Excellent practitioners, and they're like this. Okay? Till comes someone like Igor or whoever and motivates. And you know that till now, many of the implantologists in Egypt, they insist that the guy from the company would be beside them, just standing there for no reason, just to feel better. Okay? Do you know the difference between natural teeth and implants and different implant types? By the way, most implant types are good. A well-integrated support for a prosthetic appliance, that's what we need. A big store of soft tissue. Splinted rigid restoration. Minimum amount of dead spaces, and I think Dr. Bayer showed a crazy photo this morning of like 1,000 implants in the mouth, and each implant space is called dead space, no blood. Minimal surgical intervention, and of course the lip length and the lip line is very important. Dr. Rolla yesterday was talking about short implants and wide implants. And here is the question. Would you use 2 narrow diameter implants or 1 wide diameter implant? From my point of view, from what I know, I would always go for narrow diameter because of the blood supply. The distance between the blood supply from this side to this side, whenever it's less, so healthy bone. Would you use the same concept as with natural teeth? No. And please read this. 1.4 diameter orthodontic implants offered extreme success in both vertical and angulated situations. So we are reaching somewhere. Everybody is trying to make life easier, less number of implants. See what's happening in South Africa, okay? Same, all in 4. Do you know that this car is working till today in the desert? But the manufacturer never imagined that this amount of people and luggage is going to, the car is really doing something great. Of course, I have this photo for a reason, that like last month, Dr. Mangano et al. Said one-piece narrow diameter implants can be used in fixed prosthetic rehabilitation in posterior regions in both jaws with a predictable outcome. This is a very important piece of information. From my experience with the progression of years, year after year, implants started from 1.8, then they had a rough surface done here. It was always a one-piece implant, 2.1, then 2.9, then came Brident with, I think this is an innovation. Like Dr. Giovanni said, I'm so happy that I had this material coming. I'm waiting for this to come to Egypt, and I'll show you by the end of this presentation why I'm saying this. After I'm going to show you some cases. How can you restore this in 20 minutes? It goes like Dr. Giovanni was showing, very limited space, young girl, no, I don't want surgery, nothing. No flap, and then modification of the abutment and temporization. 3 months later, okay, is the final look. Another case where this guy had trauma and lost this tooth. And what they did for, and you can see no cortical bone, very, very thin amount of bone. They put a pontic in his splint, which he was wearing 24 hours a day. That's how he came. And what we did was like punching the tissue, placing the implant. That's how he went home. And then an impression, and that's before, and that's after. This guy, he came with his father, and you can see the defect here, no bone. And I said, we must do bone grafting and things. No, please, doctor, no, no, no. Okay, we'll do a bridge, no. Okay, we use the narrow diameter implant, temporization. 4 months later, here is how we reach, and this is what I love, because every single piece of information you see here is true. 3 years later, okay? Then comes this case which finished orthodontic treatment, very narrow amount of space, preparations, splint with the cervical direction here, punching, and here is the punched tissue, removal of the soft tissue, then drilling with one drill. The main advantage of this type of implant, that it would not go through cortical bone. It would go through cancellous bone. So it's, relatively speaking, it's very safe using it. And here is how it looks like. Of course, please watch this, because this is till what I am using, except after Breeden came up with the two-piece implant. This was my fear all the time. You need at least 35 Newton per centimeter torque. And then you go to the other side, and if you read in the literature, you would find that Carl Misch said that he would do that. It looks like a Maryland bridge, by the way. This is not immediate loading at all, because it depends on the composite and bonding here. But what we do is use temporary acrylic with a concavity on both sides, mesial and distal, to share the load with the neighboring teeth. Then 6 months later, the girl came after 6 months. By the way, I'm showing this because in the States now, there is a new direction to use extra hard stone, take impression for the abutment, and do crowns. See, this is how we reached. Of course, aesthetically speaking, it's not nice, but what happened was, can you see this? 4 years later, okay? We removed and we temporized, and then we did the final restoration. This is a very funny case, a deciduous upper lateral incisor, removed, and with no drilling, just placed the implant. Inverted, by the way, they discovered a skull for a vampire a couple of days ago in Bulgaria. And this young girl, who is really pretty, an Egyptian pretty girl, had upper deciduous cuspids and lower Dracula cuspids. What we did is decided for implants up there, but we had to improve the lower occlusal plane, and that's what we did. Then we temporized the deciduous cuspids for a while, just to see what's going on. Then we removed the cuspids, started to place the implants. You can see the palatal direction because there is no bone up there. No permanent teeth, so no bone. Very thin amount of bone. Playing it safe and placing the implants with temporary crowns, and then finalizing the lower teeth also to look nice. And this is before and this is after. Miracles happen. This old guy came to me with 1, 2, 3 roots, and this have been in his mouth for around 15 years. This is how the bridge looked like. I almost removed it with my hand, placed narrow diameter implants, temporized. 10 months later, he came, and this is, when you see those implants, you know how stable they are because there is no redness, no inflammation. What if a guy comes to you and say, I'm going to get married tomorrow for the third wife? And he's not a rich guy, but please, doctor, I need to feel secure getting married, and this is a real story. That's how he looked like. So we went ahead and used narrow diameter implants, temporized. That's how he got married. Later on, you can see the finalization with total porcelain coverage. From my point of view, splinting is the key for success. The first case I showed you with the combination between temporary implants and permanent, you know what happened? Years later, the upper bridge got fractured, which depending on natural teeth, okay? And here was the old bridge. What we did is use those narrow diameter implants and finalize. An American patient who lives in Alexandria, I don't know how he left himself like this, but nothing, no partial denture, nothing. He wanted a diastema. He had a very long lip. We prepared the temporary bridge, made preparations and root canals for the natural abutments. Then we went ahead and placed implants, narrow diameter again, and we relined the bridge. Then he went home this way, stayed for a few months, and then came back where we did the final procedures, and that's the diastema he was dreaming of. How would you know about restoring vertical dimension unless you are a prosthodontist? You must be a prosthodontist, even if you are an oral surgeon or a periodontist or whatever. You must know. Because a case like this, whatever you do, there's no space. So you must have this in mind. It's a big issue, and it's not around the books and textbooks of even prostho. Not a lot of people talk about restoring vertical dimension. And this is a lifesaver, and you should have it in mind before working, okay? Because if you don't restore vertical dimension, then you are not giving the optimum treatment for the patient. This is how she left the office at the same visit. This guy who came from Sudan, he has a missing upper central. He didn't want anybody to touch this part. He said, people know me this way. I want to restore this area and this area. What we did is go ahead and use narrow diameter implants, and you can see placement of the implant is very easy, no flaps. But here is a very important photo that I would like to share with you, okay? After the temporization, he went back to see this, okay? This is beautiful for whoever is thinking about the soft tissue cuff. Then he came for finalization, and we did even the other side, okay? You can see the other side. But of course I'm not showing all the cases. What's the main problem? It looks very easy, and it is very easy. The main problem is if you are placing the implant and there's no enough torque, and it's one-piece implant, what are you going to do? That's a big problem. So you need two-piece implant. In a case like this, okay? And we decided to put two narrow diameter implants here. I was not sure about the consistency of the bone, so I got a couple of implants from Bredent. We used them, felt so happy and confident. And here are the implants, but the torque was 35 Newton per centimeter, so I was able to place the abutments, and that's how the patient went home. I really appreciate this, and I'm waiting for it to come to Egypt. I'm very serious, okay? It makes life easier, no need for lots of surgeries. By the way, most of the patients do not swell, do not feel pain, okay? So what else do we need? And if we reach immediate loading through this, then life is going to be better. And thank you very much.